Assalamualaikum and good morning. My name is Aqilah binti TAJUDDIN, and my first case study is iron deficiency anemia in pregnancy. Chapter 1, Introduction. The socio-demographic of Mrs. S. The age of Mrs. S is 29 years old and the gestational age is 19 weeks. There is no past medical history of Mrs. S, and the HB latest for Mrs. S is 10.2 and the HB booking is 10.1. Because the HB level is lower the reference number, she was diagnosed with iron deficiency anemia. She was also described with iron tablet hematinic. Chapter 2, the medical diagnosis. Mrs. S' first pregnancy, and she was diagnosed with iron deficiency anemia in her 12th week of pregnancy, which the hemoglobin booking is 10.1. The latest during 19 weeks of pregnancy, the reading of her hemoglobin is 10.2. Chapter 3, the diet diagnosis relation. The etiology of Mrs. S' condition is due to the insufficient source of iron in her body. This is proven in her 24-hour diet recall. In her 24-hour diet recall, it is found that she consumes inadequate amount of iron-based food, particularly heme iron, which is red meat, liver, and cockle. While for non-heme iron fruits and vegetables and nut intake is also low, which this contribute to the insufficient iron in the body. Chapter 4, Medication Drugs. Mrs. S was described with iron tablets, which is hematinic iron tablet, 1 dose daily. It is the agent used for the formation of blood to treat various types of anemia. These tablets iron include iron, vitamin B12 and folic acid. Iron is essential in body constituent. Total body iron in adult is 2.5 to 5 gram, which is average is 3.5 gram. Iron is then distributed into hemoglobin, ferritin, homocysteine, myoglobin, and parenchymal iron. The daily requirement for iron for pregnant women is between 3 to 5 microgram per kg. Chapter 5, Nutritional Assessment and Intervention. This is the anthropometric data of Mrs. S. The BMI of Mrs. S during her pre-pregnancy is normal. Next, for the biochemistry data of Mrs. S. During the booking, the hemoglobin level is 10.1 and the latest hemoglobin level is 10.2, which this result is still far from the normal range of hemoglobin level, which is more than 11. She is considered as mild anemia. This is the dietary intake of Mrs. S. We can see here that she consumed low intake of protein and fruits and vegetables from heme and non-heme iron-based food. The nutritional diagnosis for Mrs. S condition is low hemoglobin level are related to pregnancy and low intake of iron as evidenced by a hemoglobin level of 10.2 during 19 weeks of pregnancy. Next is the strategies of diet planning for Mrs. S condition. By increasing the intake of protein from the animal sources more than the plant sources will increase the iron intake in her body. Also, she needs to incorporate the milk with juice of fruits and vegetables that high in vitamin C content, because vitamin C can enhance the absorption of iron in the body. She also needs to avoid taking milk for at least an hour from the main meal. Avoid the food that can reduce the absorption of iron, such as chocolate, coffee, milk, and tea from the main meal. Next is the energy requirement for Mrs. S. After the calculation have been made, I found that the energy requirement for Mrs. S is 1,280 kilocal per day. The additional energy requirements during pregnancy during the first trimester of Mrs. S, she need extra 80 kilocal per day. This is the macronutrient distribution of Mrs. S. I divided the percentage of carbohydrate to 55%, protein 20%, and fat 25%. For the exchange, for carbohydrate is 8 exchange, protein 5 exchange, and fat 1 exchange. This is the food exchange table of Mrs. S. The food exchange table is done based on the energy requirement of Mrs. S, which is 1,280 kilocal per day. This is the menu planning of Mrs. S for weekday and weekend. The menu planning is done based on the strategies of planning which have been explained before. Next is Chapter 6, the discussion. Iron deficiency anemia is one of the main types of anemia. It is a condition in which the blood of an individual suffering with it lacks enough of red blood cell. The role of red blood cell is critical in transporting of oxygen to the body of tissue in the individual for the efficient functioning. Such a condition develops in a patient due to insufficient amount of iron in the blood. Reduced level of iron lead towards its deficiency and ultimately iron deficiency anemia. If the body has diminished supply of iron, then it means that it also has decreased production of RBC. The deficiency of iron might be result from the decreased dietary iron, and there may be problem in the absorption, or the iron may be less bioavailable. It may also occur as a result of diminished iron stores in the body, increased loss of iron through bleeding, or increased demands of iron, for example, in pregnancy. During pregnancy, iron deficiency anemia is associated with suboptimal fetal outcome, low birth weight, and preterm delivery, along with increased risk of maternal morbidity and mortality. Pregnancy and lactation result in increased iron demand. The nutritional status is the key in preventing iron deficiency. A healthy varied diet can be routinely supplemented with prophylactic doses of iron to prevent depletion of iron stores. The total iron intake during pregnancy should not be less than 1,000 mg. A recent study found that the most pregnant women were not receiving adequate amount of iron despite taking fortified food and supplementation. Vegetarians and vegans may require additional iron fortified food and supplementation to prevent the possible shortage of dietary intake. For the Chapter 7, the conclusion. In conclusion, adequate iron intake is crucial for healthy pregnancy. Mrs. S iron deficiency anemia is caused by low consumption of iron-containing food. She was diagnosed with IDA after hemoglobin level dropped below 11, starting on the first booking. The intervention that provided for Mrs. S is she need to include significant amount of iron-rich food in address for this issue. Fruits and vegetables that can help in the iron absorption, such as high in vitamin C, also need to be included in her diet plan. Meanwhile, foods or drinks that inhibit the iron absorption, such as chocolate and milk, need to be avoided during consuming the main meal, as they can diminish or limit the iron absorption efficiency in Mrs. S body. The second case study is wasted and underweight in children. For the chapter 1 is the introduction. This is the socio-demographic data of baby M. The age is 5 months years old. The gender is female. Current anthropometric is, as stated, is on here. The past medical history of her mother. Her mother is diagnosed with fibroid before pregnancy. After pregnancy, the mother was diagnosed with GDM and anemia. There is no medication prescribed to the baby. The occupation of the mother is working at a clinic and she is staying at a Tasca. Her family did not smoke or consume any alcohol. She is the first child in the family that consists of mother and father. Next is the chapter 2, medical diagnosis. Baby M is a 5 months old baby, female baby, which diagnosed with a condition known as underweight and wasting. The birth weight of baby M is 2.3 kg and she was born during 38 weeks of mother pregnancy. During pregnancy, her mother was diagnosed with anemia, gestational diabetes mellitus, GDM, and fibroid. This suggesting that her mother conditions during pregnancy may influence baby M's current state. Next is chapter 3, diet diagnosis relation. The etiology of baby M condition is due to the incorrect breastfeeding method by the mother and also because of the low birth weight. Since birth, baby M had an abnormal growth development. The Z-score of the weight of age and BMI for age are below -3 and -1 respectively. Hence, she was diagnosed with underweight and wasting. Next, for the chapter 4, medication and drugs. There is no drugs was prescribed to the patient. Chapter 5, the nutritional assessment and intervention. Next is the anthropometric data of baby M. Baby M got a weight for age. The category of weight for age for baby M is low body weight, which is kurang berat badan teruk, and wasted for BMI for age, which is bantut teruk. This is a dietary assessment of baby M. Her mother mixed the formula milk and breast milk. The formula milk intake is per day is 4 to 5, which with the serving size 3 ounce per bottle. For the breastfeeding milk, 5 to 6 times per day, with 0 to 30 minutes duration using a both side of breast. For the nutrition diagnosis, underweight and wasting are related to low energy intake as evidenced by Z-score of below -3 for weight for age and below -1 for BMI for age. Strategies of diet planning and intervention that have been given to baby M is to use one side of breast when giving the breast milk to the baby until that one side is finished, and take time between 10 minutes to 20 minutes to make sure that the baby get both formula and hint milk from the mother. Breast milk with a comfortable position for both mother and baby. Give the baby milk as often as possible. Next, for the chapter 6 is the discussion. National Health and Mobility Survey NHMS 2019 stated that the prevalence of wasting, stunting and underweight among Malaysian children under 5 years were 9.4%, 21.8%, 14.1% respectively. Undernutrition is often measured by stunting, wasting and underweight. Many factors had been identified as being associated with undernutrition, such as parental literacy, family size, duration of breastfeeding, health status, and history of children's recent illness. The parents' perception of their children's poor appetite also reflected wasting among the children, whereby children experience weight loss due to acute malnutrition. Improvement of water supply and cooked foods in the household have also been reported to reduce the risk of foodborne disease among children and thus lower the risk of undernutrition. Last for the conclusion. In conclusion, baby M is a 5-month-old female baby which has been diagnosed with underweight and wasting. Underweight and wasting occur because several factors, which is the method of breast milk feeding, socio-economic status of the parents, and environmental factor, and also the misconception parents of child poor eating. These factors need to overcome with the help of government to educate the parents and also the parents itself to improve their lifestyle condition. This is the reference of this case study. That's all from me. Thank you.